I think that now is the time to start with the meeting. And the first lecture in this meeting will be given by Professor Bengt Winblad. It is a pleasure to introduce Professor Bengt Winblad from the Karolinska Institute in Stockholm. Professor Winblad is working in aspects related with epidemiology, genetics, and treatment of dementia conditions, especially Alzheimer's disease. The Karolinska Institute is one of the top biochemical institutions in the world, and there are at least 3 features that should have a professor at the Karolinska Institute. First, the professor should have an excellent curriculum vitae. Looking to the scientific publication of Professor Winblad, there are articles in journals like Nature Genetics, Lancet Neurology, etc., etc. We know about his pioneer initiative in pharmaceutical treatment for dementia regarding compounds like memantine or donepezil. Also, he has many honors and awards indicating that Professor Winblad is one of the leaders in the Alzheimer's disease field. A second feature that should have a professor at Karolinska is to develop an excellent mentorship. In this way, Professor Winblad is creating a school of relevant neuroscientists. And the third feature is to have or to take care of the institution, to increase its scientific level through a proper management. This has also been done by Professor Winblad. Then I hope that we can learn from him how to increase our knowledge and analysis in the study of Alzheimer's disease. The title of his conference is Alzheimer's disease, present and future, treatment strategies. Professor Winblad, welcome to Spain.
Thanks, Professor Avila, for this nice introduction. Thanks also for the invitation to come here and give an opening lecture. I must say I'm also really impressed that Her Majesty Queen Sofia is attending the conference, and I've followed your efforts during the last, I would say, 5-10 years to also develop a translational center for caring with, I would say, daycare, nursing home, but also scientific investigations. And that's a model, I would say, for all European countries. And thanks a lot for these efforts. That's this. Yes, thanks. Okay, good. My talk, as you heard, will be about treatment strategies. I will certainly focus on the pharmacological treatment strategies, but I will start up with some background data as it's the opening lecture. This slide is actually from the Alzheimer Disease International. It's made by Anders Wimo, who is actually a Swedish general practitioner working up in the north of Sweden. And you can see on this slide that we are seeing increasing demand of developing new treatment strategies. We are from 2015 to 2050, we are increasing the number of demented worldwide from 46 million to 131 million individuals. So we see one new case in the world every 3 seconds. And up to the right, you can see that the cost of dementia care, the total societal cost, is around $1 trillion. It's like I would say, the economic budget for a country like Turkey or the Netherlands. Down to the right, you can see that we in Europe have around 10.5 million demented. Most demented are certainly in the more eastern countries that are heavily populated. And as we know that age is the most important risk factor, we see an increase, a larger increase in the less developed country where the population is aging more quickly, I would say. This is a bit of epidemiology. To the right, we can see that age is the most important risk factor. With increasing age, we see more demented individuals. And to the left on the map, you can see that we have red and dark red colors. That's certainly heavily populated countries also are having most demented individuals. I mean, you see Spain has a number between 500,000 and 1 million demented. It might be even larger. The societal cost for dementia is very different in different parts of the world. And we have here divided according to the World Bank income groups. You see low-income countries at the top, lower middle-income countries up to high-income countries. And high-income countries are mainly the, I would say, Western European countries, where we have a total societal cost per demented individual up to $30,000 US. The more yellow part is the difficult part in economic calculation. Is how should we cost informal care cost, what the spouse is doing, for example. And you can see that in the low and lower middle income countries on the top, we mostly have to rely on caregivers doing the whole care. We have little of medical or social care costs, while in the high-income countries, certainly we have more cost out in the communities. I mean, especially when we have built out much of the nursing home. That's certainly a very cost-driving factor. Just coming back to actually what Alois Alzheimer described more than 100 years ago. He described it in his first talk in 1906, this case report of Auguste D., where he described the shrinkage of the brain. With advancing dementia, you lose 200 to 300 grams of brain tissue. And up to the right, you can see the histopathological hallmarks of the disease. And down to the right, you see the senile plaques with the central core of amyloid. And you see the more intracellular changes that we call NFTs, neurofibrillary tangles, that are certainly inhibiting the transportation of intracellular, for example, neurotransmitters. Today, and also actually described by Alzheimer, we know more about the inflammatory process. We know much more about how the glial cells and astrocytes are increased. We know more about the loss of synapses that very well correlate to the degree of dementia in the patients. The prevailing hypothesis causing the disorders have for many years been the amyloid cascade hypothesis. And this was based on that we, in some of these rare familial cases where we see an autosomal dominant inheritance, I mean, it's 50% chance that the child will have the disease, also saw an increased amyloid turnover. And to the right, then we saw the aggregation into fibrils, and to the most to the right, the senile plaques. The relation to the tangles is very much discussed, but today we certainly see big efforts also to focus on treatment strategies. I'll come back to that, directed more to the tangle formation. And we should remember that there is a better correlation, I would say, between tangle pathology and degree of dementia. The clinical symptoms, mostly I would say the first symptoms are memory problems, especially about episodic memory function. What were we having to lunch today? What were we doing yesterday evening, etc. But when the disease progresses, we also see other cognitive declines, impaired language, difficulties to perform activities of daily living, loss of orientation, difficult to find the way in the surrounding, visuospatial problems, and certainly the disease progresses continuously. And it's a we should remember a malignant disease. I mean, from diagnosis to death, the expected lifespan is half of that for a non-demented individual. A large progress or improvement has been regarding the clinical diagnosis. Today, the diagnosis is put mostly as a teamwork. The doctors collaborate with the neuropsychologists, the physiotherapists, the social workers, and the community nurses, and certainly also with the patients and the caregivers. The advancement during the last 10 years has mainly been to include better tests on imaging. We have functional tests, we see how the brain is functioning. We have the SPECT and the positron emission tomography. We have developed the neuropsychological test battery. And we have also looked more on other biomarkers like those in cerebrospinal fluid and in blood. Much worries from the patients and the families is this a genetic disorder? What is the risk of us getting the disease? And it's important, I think, to have a genetic, make a family tree and inform the family about the prognosis. And finally, there is a sort of consensus diagnosis after all these tests have been done and you have summarized the data. We have also seen a development regarding the diagnostic criteria, we could say. And today we do put the diagnosis of Alzheimer's disease at least 10 years earlier than we did 25 years ago. And the reason to that is mainly the use of these biomarkers. And up here you can see earlier we had a standard diagnosis. Today we also include amyloid biomarkers or any biomarkers, and we include better neuropsychological tests. And the new, I would say, research criteria are even talking about preclinical or pre-symptomatic Alzheimer's disease, meaning that the individuals have no symptoms, but they have positive biomarkers, and we can be rather certain that we give a diagnosis of pre-symptomatic Alzheimer's disease. And there is a need to be more specific regarding subtypes, and because in the future I think we will have a very much more individualized therapy. We could call it personalized medicine. This is a simple picture about performing the lumbar puncture. In our country, for example, we do it on every patient coming in. It's like taking a blood sample. It's very, very few side effects, and it helps us a lot in the diagnostic process. It helps us a lot to select patients for clinical trials, and also helps us as an outcome measure if we could, with the drug that we test, if we could influence these biomarkers. And in the 90s, the first publications came out on cerebrospinal fluid showing that, to the left here you see the Alzheimer patients dotted, and to the right healthy controls, and you can see that A-beta 42 was decreased in the CSF of Alzheimer patients compared to healthy elderly. Just to show you the other biomarkers, I mean, today we have positron emission tomography. We could label amyloid, we could label tau, we could label inflammatory cells, and we have a lot of ligands labeling different parts in the pathogenesis of the disease. And down in the bottom line, this is a slide from Agneta Norberg, we can see those patients having a clinical diagnosis of MCI, mild cognitive impairment, only slight memory problems, subjective complaints, and we could verify it with neuropsychological tests. And then the upper line are these patients, the same patients after 3 years. And to the left, you can see those that converted to Alzheimer's disease here, up to the left. I'm bad on this. And here are these that not converted, because see the HC, the healthy controls. How do I do this? And what was obvious was that those that converted to Alzheimer's disease, they already at baseline had an amyloid pathology in their brains. Another part is the possibility of prevention. How can we use our European good data from the epidemiological studies? And in Europe, we have seen recently 3 larger prevention trials going on. One is the finger study from our group, led by Mia Kivipelto. One is the MAP study from Bordeaux, and one is the PREDIVA studies from the Netherlands. And you can see that all these studies have a multi-domain intervention. If you look on the finger study, you have take care about the blood pressure, the pre-diabetes, you inform the patient about what to eat, the diet, you have physical exercise, and you have cognitive training. And the results from that study were published, as you see at the bottom here, in the Lancet by Mia Kivipelto's group, and a 2-year, I must say, intervention with this multi-domain training gave a positive outcome. It reduced or delayed the onset of dementia, and it improved the cognitive performance of the individuals. So we today see similar good effects as we see with the first generation of drugs using this multi-domain training. And perhaps in the future, we will use the combination of interventions like this and pharmaceutical treatment strategies. If you go over to the pharmaceutical interventions, and I depicted a picture of Alois Alzheimer. He died in 1915. He looks on this picture very optimistic, and I think he was thinking probably we have a treatment strategy in 10 years, but more than 100 years have passed until we have the first generation of drugs, and you know the cholinergic drugs, and you know on top memantine. And now at 2015 we are expecting the first results of antibodies that probably, hopefully, will have a disease-modifying effect, arrest the disorder, or at least reduce the decline, cognitive decline or impairment. So I think he's surprised it took so long time, but still happy to see that so much is in the pipeline. And I think we are facing the coming years where we see several phase 3 trials being ready and published. Still today, we have the first generation of drugs, and we also see that it's important to combine these therapies, and these are studies from Oscar Lopez in the US, who did. In the US, they usually do combination of memantine and a cholinergic drug from start, as soon as the diagnosis is set. And you can see here on top, if we have a green, that's the combination. The red ones are cholinergic drugs alone, and at the bottom we see those that are untreated. And if we follow the black dots, we can see that in 7.5 years of follow-up time, almost 80% have moved from home to a nursing home. If we have the red dots, we can see that only 35% had moved from home to a nursing home. And if we look on the combination, the green dots, we can see that in 7.5 years follow-up, only 20% with the combination had moved from home to a nursing home. And of course, for our societies, this is a large economic gain. It's a cheaper form of living to live at home than in a nursing home. And for the patients, and probably hopefully for the caregivers, it's also a big advantage. This is a slide to show you the optimistic view I have on clinical trials. Still, we should remember there are almost 200 trials who have failed, and rather few who have been positive. But now when I look on this, and this is actually a bit old now, it's since We updated an early publication in 2013, and if you look on the left on all these red dots, that's molecules influencing the beta amyloid metabolism, either decreasing the production, like gamma or beta secretase inhibitors, or inhibiting the aggregation, or the immunotherapy trials increasing the clearance of A-beta. The blue dots are those that are influencing tau, the neurofibrillary tangle formation, and if I compare 2010 and 2013, there is an increase in number of molecules tested against the tau phosphorylation or aggregation. And the green dots to the right are those that were traditionally cholinergic molecules, but now have different modes of action. You can see close to the middle, you can see statins, insulin, antioxidants, etc. So it's not only cholinergics. And some also have double modes of action. They could increase the cholinergic activity and on the same time influence the beta amyloid metabolism. And you can see that it's divided into different phases, phase 1, phase 2, and phase 3. And phase 3 is the studies we have to do to get a molecule approved by FDA, Food and Drug Administration, or the EMEA in London, the European centralized organization to approve molecules. In the clinic still, we also need drugs that have a symptomatic effect. We need to decrease the anxiety, the depressive symptoms with patients. We need to stimulate them, increase their understanding, talking more, etc. And I have listed here a series of molecules that are affecting the classical neurotransmitters, like acetylcholine. You can stimulate the nicotine receptors, serotonin. I mentioned 5-HT6 antagonists. We have 2 large phase 3 trials with one Danish and one US company doing this, or norepinephrine. We have MAO-B inhibitors, monoamine oxidase inhibitors, actually increasing the activity in several of the neurotransmitter systems. So even in this, it's not only to modify the disease or the progression of the disease, but also molecules being tested to improve, that have a more direct symptomatic effect. If you look on the amyloid-related approaches more in detail, you can see from left, we can influence the production of the amyloid, beta amyloid. We can inhibit the aggregation, or we can inhibit the deposition, or we can increase the release, as I said, with the immunotherapy. And those in I would say, dark red or violet are indicating some of the molecules that are in a late clinical testing phase. You see the beta and gamma secretase inhibitors. Unfortunately, we had some side effects with the gamma secretase inhibitors, but now there are molecules that inhibit the beta secretase, and that has good support from genetic studies from Iceland, where they saw in a small part of the population who had a mutation really acting as a beta secretase inhibitor, the risk of getting Alzheimer's disease was far reduced in that part of the population. So there is support in the population for affecting these secretases. Down in the bottom, you see those that inhibit the fibril formation. Skyroinositol, it's still, as I have understood, in a phase 3 trial. And up to the right, you see the number of antibodies, solanezumab, crenezumab, gantenerumab, aducanumab, and CAD-106. The 4 first are antibodies. That's what we call passive immunotherapies, and the CAD-106 is an active immunization. We give part of the A-beta molecule, the patients develop the antibodies, and the antibodies go up into the brain and bind to the oligomers and the plaques and remove the beta amyloid from the brain. So we have the active approach and we have the passive approach. In the passive approach, we produce antibodies in mice or eventually rabbits, humanize them, and have to inject into the patients, I would say, every month for the rest of their life. Advantage here, that's a more expensive form. If we can actively vaccinate, it's cheaper, but we have a bit more difficult to keep control over side effects. These are some slides about active immunotherapy, where we in Sweden have been very active in the early stages of this development. The sponsor is Novartis, and you can see on the curves here that we did 1, 2, 3, or 4 injections, but the concentration were going up and then declining over time. And if we do 3 more injections or 4 more injections, then we can induce an antibody titer that is more constant over time, running up to 3 or 4 years. So we are just now looking how many injections do you need to do, how many booster doses do you need to give with this. This active immunotherapy, CIIIEN, is now out in a phase 3 trial done in the US, where they select a population of ApoE4 positive, having 2 alleles of ApoE4. So a very selected population that with high probability develop an amyloid in the brain. Passive immunotherapy, you might know that the first studies with the bapinezumab failed, I would say, and the more interesting part is solanezumab, and I mentioned that when they pooled 2 studies, they got a positive effect in the mild stages of the disease, and they are now out into a phase 3 trial where the last patient is just leaving the study, and we will have the results presented in the beginning of December in the clinical trials in Alzheimer's disease conference in US in the beginning of December. During the last weeks, we have heard much about the aducanumab phase 1 study. It's an interesting antibody. It was developed in Zurich, actually, by the Christoph Hock and Rodinich, and they got the idea that if we have a 100-year-old person who is absolutely cognitively intact, they must have antibodies that protect them from the disease, and they were developing these antibodies and are now using them in these trials. And you can see in this early study, just published, in 166 persons with early stages of the disease, they can see a dose-dependent reduction of amyloid into the brain. And when they gave the highest dosage, they had 4 dosages and 1 placebo group, they reduced the amyloid content with 90%. And what was interesting was that they also reduced the decline in MMSE and CDR sum of boxes as a cognitive test. They could reduce the decline compared to what happened in the placebo-treated patients. There are also more specific studies in specific populations. I'm, as a European, sad to say that all these are done in the US. I don't know why we cannot manage to do it in Europe, but you can see on the first 2 up here, it's made on patients having a presenilin mutation, and it's Colombian families that are really having an enormous number of individuals. You can see they are investigating 300 members of that family tree. It's a DIAN study where they assess patients who have the mutation, one of the mutations leading to Alzheimer's disease, either in the presenilin gene or in the APP gene. And they have now assembled 210 members. And then they have 3 groups here where they have healthy senior individuals, where they, by imaging, for example, or CSF, or really assembling individuals who have amyloid in their brains but still having no symptoms. And you can see on the treatments that it's different forms of antibody, but it's also here a molecule that is actually used earlier as an anti-diabetic that is very similar, I would say, to a beta secretase inhibitor, if I look on the structure of it. And they have also, in this last study, included a BACE inhibitor. So if you now turn over to the tau-related approaches, we can see that there have been several attempts. Some turned out to have no effect or to have more side effects, negative studies. But in the recent years, there have been much talked about this, we could call it a methylene blue-like substance that inhibits the aggregation of the tau protein. It was a recent report in Toronto where the study results were a bit doubtful. I would regard them as negative, but more analysis is going to be done. And in a group of frontotemporal lobe dementia patients, it was negative. In the bottom here, you can see I put up 2 studies, one with AADVAC1 and ACI35. Actually from 2 European pharmaceutical companies, one in Bratislava and one in Lausanne. And these studies are now moving into phase 2, and the Lausanne group is performing the phase 1 study. If I look on the preliminary data from phase 1 in the Bratislava study, it was performed actually in Austria. This is an active vaccine against tau aggregation or hyperphosphorylation, and the preliminary results showed that here with this vaccine you got a very robust immune response increasing after each dosage. And when you looked on the cognitive scales, for example, the ADAS-Cog score, they were stable over 6 months. It's a phase 1 study. It's actually not meant to measure clinical outcomes, but these data are, I would say, promising, and the company decided now to start, and they have started a phase 2 trial. It's not only amyloid and tau. We also have a next generation of targets, and we are really helped by the large genetic genome-wide association studies, and we have indications of pathways that could be influenced, for example, neuroinflammation. We know that the synaptic dysfunction could be very much dependent on the function of the mitochondria. The mitochondria are those elements producing the energy. And of course, if these are damaged, we see a synaptic loss. We could also influence the lipid biology. Is cholesterol reducing strategies of value? How should we target ApoE4, ApoE3, ApoE2 individuals? That's upcoming studies, I would say. In our lab, we have taken many approaches. One has been, we have studied the BRCA protein. We know that if you have a mutation in the BRCA part molecule, that we get a dementia. We could call it the British dementia. It's a mutation in the BRCA domain, and the Danish dementia also. And we know that the BRCA protein inhibits the fibrillation or the aggregation of A-beta. And we are now over into the first in vivo studies. We do those in Drosophila, in fruit flies, and it seems that it has a very nice, if you can activate BRCA, it's really improving the condition both in the mice and in the flies. Another approach where we are more in the clinic is to give nerve growth factor to our individuals. The problem here is that it doesn't pass the blood-brain barrier. We have to use more direct surgical methods, and it was actually the Italian researcher Rita Montalcini who got the Nobel Prize for her basic discoveries here. And what we have done is that we have now, after a lot of problems, infusing it directly into the side ventricle of our patients, we have now developed a catheter where we, in the tip of the catheter, have cells that overproduce NGF. And this is like a semi-permeable membrane. We have the cells, and we, with help of neurosurgeons, put in the catheter, and they secrete then NGF in the surrounding of the nerve cell bodies of the cholinergic cells down into the locus or nucleus of mind, we could say. In 10 patients that we have run, we can see a stabilization in 5 of those. 5 are still having a progression of the disease. We did this for 1 year, implant the catheter on both sides. And these studies are ongoing. It's certainly to test the idea. We certainly realize we need to have some other ways of administration in the future. So if I summarize the research, where will we be in 2025, we could say? I can say in this area down here, you can see that we have today much better knowledge about defining subtypes of the disorder. That gives a better possibility for specific drugs to act on this, having a specific influence on specific mechanisms. If we look on the top here, we can say regarding beta amyloid, we are getting the first results of the antibody trials already in December. I'm personally not convinced about that they will be positive. I think we have a better possibility if we go into the familial cases where I said we have a real overproduction of A-beta. Regarding tau, the next here, we can see that the first phase 1 studies are ongoing or have been ended. Seems to be positive. I'm not sure about the methylene blue REMBER part in phase 3. Regarding neuroprotection, we have antioxidants, we have the growth factors, and I mentioned our NGF trials. Regarding risk inhibition, we know certainly a lot in Europe from our large and good epidemiological studies, and I mentioned the intervention trials with multimodal training or cognitive training and diet, etc. But much is coming back to these, I would say, genetic findings that can be influence ApoE4, the negative effect. Should we decrease cholesterol? What is the effect of statins? Are they toxic or not? Should they be more or less lipidophilic? Inflammation, how should the balance be? But ending up with this, I think still the most important part is that we have to stimulate the basic research. We have to know more. And I think, and I hope that the European authorities realize that without basic research, we will have no drug development. And drug development and drug discovery is a long-lasting process. You know that the patent time is 20 years for a discovery, and it's estimated that from the idea, I would say, passing to production to phase 1 in healthy individuals up to phase 2 and phase 3, it's a time of 10 to 12 years in the development. So there is a rather short time period left for the patent in this. Still, with Queen Sofia here, I want to mention again that I think the most largest advancement or improvement has been in improving the care of the patients. And for me, certainly the most important part is for patients who are in the later stages of the disease. And in my country, often this care is done in some sort of nursing homes or specific types of living, more friendly. And if I summarize the research findings, I see that how much a nice, friendly environment means for the patients, what a good staffing means, and you should have a proper competence. And today it's a tendency, I would say, to reduce the medical competence, but for me, for example, the nurses are of extremely good help in this. They have a natural diagnostic and prognostic thinking. They could reduce symptoms but just by using a good interaction with the patients. And we who have influence should certainly stimulate that they have more influence, that they are well paid. We need to have a staff continuity, presence and generosity. I mean, in my country, when it's a good economy, people leave, they go to McDonald's and work there, they earn more money. So I think we should really put forward that we need staff continuity. And in each unit here, we have to employ good unit leaders. They, in a way, make the philosophy, they make the quality in the care. And what we need is to meet basic needs and give relief. And in all these types of settings, we need a very humanistic philosophy. So these are my collaborators, and thanks to many more, of course. Thank you. Yeah, if you have time. One.
Okay, we have a short time for one or two questions. Short questions.
If no questions. You have one. That's
in one of your slides, the slide that was taken from a figure of Lancet Neurology about the ongoing clinical trials in different phases, you indicate that insulin is now in phase 3.
Which one?
Insulin.
Insulin, yeah.
Like now, it's a story that if some people said that Alzheimer's disease could be diabetes type 3, could you comment anything about that?
Yeah, I think the more studies are needed regarding the glucose metabolism. But if you go back to epidemiology, there are clear indications that diabetes mellitus, either type 1 or type 2, are both risk factors for dementia. And we also know that we have insulin receptors in the brain. And of course, if they are deranged with aging and still more in dementia, I think that could be an approach to try to stimulate the glucose metabolism. And we have excellent outcome markers like FDG PET, fluorodeoxyglucose PET. So I think it's an area where I, as I said last, need more basic research to do. We also have good animal models with the old streptozotocin models that you very well know.
Another question? Okay.
It's another Jesus.
Thank you very much for coming here. This is Jesus de Pedro. My question has to do with limits of disease. With limits of disease, with boundaries. Yeah. It seems that some people think that in the late life neurodegeneration, sometimes there is difficult to find the limits between, for example, Alzheimer and Lewy bodies for Alzheimer and vascular dementia. Right. And how do you think about this idea which could point to the fact that there is a continuum and it is difficult to identify a unique target?
Yeah, I would say it's certainly more difficult in the high ages to be very specific, but it's a very clear-cut thing that cognition and activities of daily living in a normal, healthy individual are not influenced to the degree that we see in a dementia. And that's the basis for the original diagnostic and classification of the disorder. It's more clear in the early onset cases. I mean, there we have really and we can also do a more type-specific diagnosis. So I would say with normal aging, when we accept arteriosclerosis being aging phenomenon, of course, they go together more. And we also see lesser differences in, for example, the neurochemistry between a normal 95-year-old and a demented one. But for me, it's certainly a specific entity with a specific diagnostic criteria separated from normal aging.
Okay, thank you very much, Professor Winblad. And then now we can go to the next step of this meeting. Okay.